Welcome to the deep dive. We're tackling a really critical topic today, basically pulling apart your MSRA revision notes on human immunodeficiency virus, that's HIV, of course. Think of this as your focused guide. We're cutting through the noise to get straight to the high-yield essentials you need.
Exactly. Our goal is to take all the information you've gathered for revision and structure it, in a way that actually makes sense and helps it stick.
Mm.
We'll trace the path of HIV,
hmm
what it is, how it works, right through to diagnosis, management, and what the outlook is.
So settle in. We've got your notes right here, and we're ready to, well, dive deep into HIV. All right, let's start building our understanding, maybe piece by piece, kicking off with the absolute foundation. What exactly is HIV, according to these notes you've got?
Okay. At its core, HIV is a viral infection, and it's insidious because it progressively targets and weakens the immune system. If it's left unchecked, this eventually leads to acquired immunodeficiency syndrome, or AIDS.
And its primary target. What part of the immune system is it really going after?
Yeah, the key target highlighted in your notes is the CD4 T-cell. These cells are, well, they're absolutely critical for coordinating the immune response, fighting off pathogens. As HIV attacks and destroys them, the body's ability to defend itself just sort of crumbles.
Okay, so it's a viral attack specifically on those crucial CD4 cells. Now, the notes mention distinct stages of infection. Why is understanding these stages important for revision, and what are the key things to remember for each?
Right, understanding the stages is definitely high yield. They pretty much dictate symptoms, how detectable the virus is, and the prognosis if it's untreated. Your notes outline four main ones. First, there's the acute primary infection. This is the very early phase, usually 1 to 6 weeks after infection. What's crucial here, and the notes point this out clearly, is that standard HIV antibody tests might still be negative.
Oh, right. That's important.
Yeah, but other markers like the viral P24 antigen and HIV RNA levels are actually very high. Clinically, it often looks like a really bad flu or glandular fever.
Okay, stage one. What's next?
Stage 2 is the asymptomatic stage, and this can last for years. The virus is still replicating, but much more slowly. People often feel completely well, and interestingly, their CD4 and CD8 levels might even look normal during this period. It's kind of the silent phase, but the virus is definitely still active.
Silent but active. Got it. Stage three.
Symptomatic HIV infection. This is where the immune system is clearly starting to struggle. You start seeing nonspecific symptoms like persistent fever, drenching night sweats, chronic diarrhea, maybe unexplained weight loss. The notes mention this is sometimes called AIDS-related complex, or ARC. It basically indicates the immune system is deteriorating, but hasn't quite hit the threshold for full AIDS.
And the final stage.
Stage 4.
AIDS.
This is defined by profound immunodeficiency. It's not just about a low CD4 count anymore. It's marked by the appearance of specific life-threatening opportunistic infections or certain cancers that, a healthy immune system would normally handle easily.
Got it. So remembering those four stages, acute, asymptomatic, symptomatic, and AIDS, and the key features of each, especially that seroconversion window where antibody tests might be negative, is vital.
Absolutely vital. Now, moving from what it is to how it gets from one person to another, the notes are very clear on the main routes of transmission.
Right, this is where it's just critical to be absolutely clear. The main ways listed are.
Well, primarily it's direct exposure to infected bodily fluids. So unprotected sexual intercourse is a major route.
Yes, and also sharing contaminated needles or syringes. That facilitates direct blood-to-blood contact, doesn't it?
It does. And thirdly, there's mother-to-child transmission. This can happen during pregnancy, childbirth, or through breastfeeding.
The notes also mention transmission through blood transfusions or organ transplants, but they add a really important point, especially for places like the UK.
Right. Because of the rigorous screening processes we have now in many countries, transmission via those routes is, thankfully, exceedingly rare compared to the big three.
Yeah.
So for your revision, you really want to lock in sexual contact, shared needles, and mother-to-child as the main transmission routes.
Okay. Knowing how it spreads leads us naturally to risk factors, the situations or behaviors that increase someone's likelihood of actually getting infected.
Precisely. And the notes list specific risk factors that, map directly onto those transmission routes we just discussed.
So things like
engaging in unprotected sex, especially with multiple partners, sharing needles for drug injection, also receiving blood or organ transplants in settings without really good screening, though, again, less common here now, and being born to an HIV-positive mother if preventative measures aren't taken.
Essentially, any scenario that creates an opportunity for that direct exchange of infected fluids, it's a list that makes complete sense when you think about how it's transmitted. So, once the virus gets into the body, how does it actually do its damage? Let's talk pathophysiology, the mechanism of the disease.
Yeah, what's particularly fascinating about HIV and really crucial for understanding why it causes disease is its specific method of attack. The notes break this down quite nicely. First, it has to get into the target cells. We mentioned it seeks out cells with CD4 receptors, mainly those critical CD4 T-cells, but also others like macrophages. It binds to these receptors to gain entry.
Okay, so it finds the door.
Finds the door, gets inside. Then, it's remarkably clever. It uses an enzyme called reverse transcriptase.
Why?
This converts its own RNA genetic material into DNA. Then another viral enzyme, integrase, helps insert this new viral DNA right into the host cell's own DNA.
Wow, okay, so it rewrites its code into ours.
Effectively, yes. Now, the host cell is essentially hijacked. It starts using its own machinery unwittingly to make new copies of the virus. These new virus particles then bud off, often destroying the host cell in the process, and they go on to infect more CD4 cells.
So the key steps are find the CD4 cell, get in, use reverse transcriptase and integrase to integrate into the host DNA, turn the cell into a virus factory, and then the resulting destruction of CD4 cells causes the immune deficiency.
Exactly. That progressive decline in CD4 cells is the absolute central mechanism behind the immunodeficiency seen in HIV and AIDS.
Right. Given that HIV weakens the immune system, someone might present with symptoms like just feeling run down or getting lots of infections. This could be various things, not just HIV. What else should clinicians be thinking about, according to the notes? The differential diagnosis, and what's the crucial next step?
Yeah, the notes definitely emphasize considering other causes of immunodeficiency when you're building your differential diagnosis.
Such as,
Well, this could include other viral infections that might suppress the immune system temporarily, certain autoimmune conditions, some types of cancer, or even congenital conditions, those primary immunodeficiency disorders someone is born with.
so the list is quite broad, but what's the absolute key takeaway here, the non-negotiable point?
You simply cannot rely on the clinical picture alone. The notes are very firm on this. You must use HIV-specific laboratory tests to confirm or rule out HIV. Other conditions can definitely mimic parts of the presentation, but only that specific test tells you for sure if HIV is involved.
Okay, let's zoom out a bit and look at the bigger picture, the epidemiology. The notes give us some quite striking data, both for the UK and globally.
They do. For the UK, prevalence is lower than in some regions, but it's still a significant public health issue. The notes highlight that it disproportionately affects certain groups, particularly men who have sex with men, some heterosexual individuals, and people who inject drugs.
And there's been some positive news regarding trends in the UK, right?
Yes, a really important positive trend. The notes show a welcome decline in new diagnoses here since around 2014, especially among gay and bisexual men. However, they also flag that late diagnoses remain a real challenge. It was still high, around 43% back in 2018, which means quite a few people are being diagnosed only when their immune system is already significantly damaged.
43% late diagnosis. That's still quite high. What about the global picture? The numbers mentioned are just, well, staggering.
They really are sobering. The notes cite 2018 data showing about 37.9 million people living with HIV worldwide. Sub-Saharan Africa carries the largest burden by far, with roughly 25.7 million people infected.
But thankfully, there's also a positive global trend mentioned, too.
Absolutely. Huge progress has been made globally. Between 2000 and 2018, new infections fell by 37%, and HIV-related deaths fell by a substantial 45%. It really highlights the impact of global treatment and prevention efforts.
So for revision, key points are the UK story, declining new diagnoses, but still an issue with late diagnosis, alongside that massive global burden, especially in Africa, but also contrasted with those significant global improvements over the last couple of decades. Okay, let's switch gears now to how this infection actually shows up in a person. What are the clinical features we should be looking out for based on your notes?
Well, the clinical presentation really varies depending on the stage of infection, which loops back to why understanding those stages we talked about earlier is so important.
Right.
Early on, many people are actually asymptomatic. They feel fine. But And this is crucial for picking it up early. And for your revision, around 60 to 80% of individuals will experience that acute seroconversion illness, usually 30 to 12 weeks after they get infected.
And remind us of those specific high-yield symptoms of that seroconversion illness, the ones to really look out for.
Think of it like a really severe flu or glandular fever. So fever, fatigue, general malaise. The notes specifically list sore throat, swollen lymph nodes as lymphadenopathy, and often a rash. Recognizing that cluster of symptoms in someone with potential exposure is absolutely critical for early diagnoses.
Okay, that's the early stage. What happens as the disease progresses if it's not treated?
Well, as the CD4 count drops further, the symptoms become more chronic
Yeah.
and really reflect that failing immune system.
Like what specifically?
Persistent, unexplained weight loss and chronic diarrhea are classic signs mentioned in the notes. And of course, the appearance of those opportunistic infections we'll talk more about later. That's a clear sign of significant immune decline and progression towards AIDS.
So, key things to remember clinically. Could be asymptomatic early on, watch for that specific seroconversion syndrome, and then look for later chronic symptoms like weight loss and diarrhea indicating worsening immune function.
Exactly. So how do we actually confirm a diagnosis and then keep track of the infection's activity and the immune system's health? The notes detail the essential investigations.
Diagnosis isn't clinical, as you said. It's all about the lab tests. What's the usual diagnostic process?
It typically starts with screening tests. These look for either HIV antibodies or the B24 antigen, or often nowadays a combination of both. If that initial screening test comes back reactive, it must be confirmed with a second, more specific test. Traditionally, this was a Western blot, but now it's more commonly a nucleic acid test, like PCR, looking directly for HIV RNA.
And that links back to the acute infection point.
Precisely. Remember we said antibodies might be negative early on?
Yeah.
The notes clarify that the P24 antigen in HIV RNA by PCR can actually detect acute infection even before antibodies develop, because the virus itself is present in high amounts.
That makes perfect sense. Viral load is high early on. What about rapid tests? Are they mentioned?
Yes. The notes mention rapid point-of-care tests are available, giving results in about 20 minutes or so. Very useful in certain settings. But, importantly, a reactive rapid test still needs confirmation with standard laboratory testing. In adults, the definitive diagnosis is primarily based on detecting those anti-HIV antibodies in the serum, confirmed by a second method.
Okay, so that's diagnosis. Once someone is diagnosed and ideally starts treatment, how is it monitored?
Monitoring is absolutely key. The two indispensable tests highlighted are the CD4 T-cell count, which gives you a snapshot of the immune system's strength, how much damage has been done.
And the viral load. That measures the virus itself.
Exactly. Viral load measures how much active virus is circulating in the blood. It tells you how effectively the virus is replicating. It's the main marker we use to see if treatment is working.
What does seeing the viral load change over time tell you, if it goes up or down?
Well, a rising viral load after it's been suppressed can be an alarm bell. It might mean someone isn't taking their medication consistently. Non-adherence is a big issue, or, more worryingly, that the virus is developing resistance to the drugs. Conversely, the goal of successful treatment is to suppress the viral load right down, ideally to undetectable levels. When that happens, the immune system, reflected in the CD4 count, usually starts to recover, and the risk of complications plummets.
Okay. The notes also specify who should be tested for HIV. Which groups are recommended?
Yeah, the key groups recommended for testing include individuals reporting high-risk behaviors, obviously. Also, people presenting with symptoms or signs that are strongly associated with HIV. The notes call these indicator conditions. And of course, sexual partners of people known to be HIV positive. Plus, routine testing in certain clinical settings, like antenatal clinics or STI clinics, is really crucial for catching infections early.
Right. This leads us perfectly into management, what can actually be done once a diagnosis is confirmed. The notes put a massive emphasis on antiretroviral therapy, RTA.
RT has completely revolutionized HIV management. It's the absolute cornerstone, no question. The strategy involves using a combination of different drugs, usually 3 or more taken together.
And why a combination? Why not just one drug?
It's all about preventing the virus from developing resistance. HIV mutates rapidly, so hitting it from multiple angles simultaneously makes it much harder for resistant strains to emerge. The goals of RT are really clear in the notes. Suppress the virus to undetectable levels, stop or even reverse immune damage, prevent progression to AIDS, and crucially, reduce the risk of transmitting the virus to others.
How do we know if the ART is actually working effectively?
Ongoing monitoring is vital. We track the viral load, that's the key marker of success, we want it undetectable. We also monitor the CD4 count to see the immune system recovering. And, of course, overall clinical health, checking for any drug side effects, and sometimes monitoring drug levels, too.
Now, the notes list several different classes of these antiretroviral drugs. They target different steps in that viral life cycle we discussed earlier. This seems like a really important section for revision. Can you walk us through the main classes?
Absolutely. If you think back to how the virus gets in and replicates, the drug classes basically interrupt different parts of that process. First, NRTIs, nucleoside reverse transcriptase inhibitors. Examples given are zidovudine, abacavir. They block that key enzyme, reverse transcriptase, by acting like salty building block.
Okay, block reverse transcriptase.
Then you have NNRTIs, non-nucleoside reverse transcriptase inhibitors, like nevirapine or efavirenz. They also target reverse transcriptase, but they bind to it differently, sort of jamming it up.
Two ways to hit reverse transcriptase. Got it.
Next up, PIs, protease inhibitors. Examples are imidavir, ritonavir. These block viral protease, an enzyme the virus needs later on to assemble new infectious virus particles.
Stops assembly. Okay.
Then integrase inhibitors. Think raltegravir or dolutegravir.
Yeah.
These block the integrase enzyme, preventing the viral DNA from being inserted into our own host cell DNA, a really key step.
Stops integration. Makes sense.
And finally, entry inhibitors. Maraviroc or enfuvirtide are examples listed. These work right at the beginning, blocking the virus from even entering the host cell in the first place.
Blocks the door, essentially.
Exactly. So for revision, know those main classes: NRTIs, NRTIs, PIs, integrase inhibitors, entry inhibitors, and roughly which step they target. The notes are also very specific about when to start ART.
Yes. What's the current recommendation?
This has changed over the years, but it's very clear now. The 2015 BHIVA guideline mentioned in the note says RT should be started immediately upon diagnosis. For everyone, regardless of their CD4 count, the evidence shows earlier is better.
Immediately upon diagnosis. That's a clear message. Management isn't just about ART, though, is it? It's also about dealing with other infections someone might have or be particularly vulnerable to.
Absolutely. Managing coexisting conditions is vital. For example, if someone also has viral hepatitis, like Hep B or C, their treatment needs careful planning because of the impact on the liver and potential drug interactions with RT. Luckily, new treatments for hepatitis C in particular have made a huge difference here.
And what about preventing those opportunistic infections that can take hold when the immune system is weakened?
Prophylaxis preventative treatment is a really important part of management, especially when the CD4 count drops below certain levels. The notes list several key examples you should know. Treating latent TB infection is crucial. Using cotrimoxazole, Septrin, to prevent pneumocystis pneumonia, or PCP, offering the pneumococcal vaccine against bacterial pneumonia. Sometimes azithromycin is considered for MAC prevention. Cotrimoxazole or dapsone for toxoplasma, and varicella immune globulin might be given after exposure to chickenpox or shingles. Interestingly, the notes point out there's no routine prophylaxis recommended for CMV or herpes simplex, though treatment is obviously given if disease develops.
Okay, that's a good list to be aware of. Finally, under management, there's prevention of spread. What public health measures are outlined?
Yeah, this is crucial. It covers a wide range, promoting safer sex practices, barrier contraception, reducing partners, needle exchange programs for people who inject drugs, controlling other STIs because they can make HIV transmission easier, raising awareness in places like STI clinics, encouraging HIV testing for pregnant women to prevent mother-to-child transmission, providing post-exposure prophylaxis, or PP, after a potential exposure, and increasingly exploring pre-exposure prophylaxis, PrEP, for individuals at high ongoing risk of acquiring HIV.
Right. Turning now towards the future for someone diagnosed today, what does the prognosis look like, according to your notes?
This is probably the most hopeful part of the whole topic, based on these notes. They make it absolutely clear. With early diagnosis and consistent effective treatment with ART, the prognosis for someone with HIV has improved dramatically.
Meaning what, exactly?
Meaning people living with HIV who are on effective ART can now expect to live long, healthy lives. Their life expectancy can be very close to that of the general population.
That's incredible progress.
It really is. But the contrast is stark, and it's important to remember this too. The notes state clearly that if left untreated, HIV inevitably progresses to AIDS. This leads to severe immune deficiency and a significantly increased risk of those life-threatening opportunistic infections and cancers we've mentioned.
So the absolute key takeaway for prognosis is that while it remains a serious chronic condition, effective treatment has transformed the outlook. from what was once often a fatal diagnosis to now being a manageable condition, allowing a near normal lifespan.
Precisely. Finally, let's touch on the potential complications of HIV, particularly if the disease is advanced or perhaps not well controlled by treatment. What specific issues are highlighted in the notes?
Well, the notes list some general categories first. Opportunistic infections are a big one, certain cancers linked to viruses, various neurological problems, and also an increased risk of things like cardiovascular disease and even non-AIDS related cancers, potentially due to chronic inflammation.
Yes, and they provide crucial details on specific examples that you really need to be aware of for revision. Things like HIV diarrhea. This is very common. It can be caused directly by the virus itself or by opportunistic gut infections like Cryptosporidium, CMV, Pavea, or Giardia. Management is often supportive, but finding the specific cause if possible is important. Kaposi sarcoma, caused by human herpes virus 8, HHV8. It classically presents as those distinctive purple or brownish lesions on the skin or mucous membranes. The notes even mention seeing this in a patient. Treatment involves things like radiotherapy or resection, but crucially, effective RT itself often leads to regression of the lesions.
Okay, Kaposi's sarcoma, what else?
Central nervous system complications. This is a really big and important category. It includes things like cerebral toxoplasmosis, caused by the parasite Toxoplasma gondii, cryptococcal meningitis, a fungal infection from Cryptococcus neoformans, also progressive multifocal leukoencephalopathy, or PML, which is caused by the JC virus, and HIV encephalopathy or dementia complex itself. Each of these has distinct features on imaging and requires specific treatment.
A lot can affect the brain.
Indeed. And also peripheral neuropathy and myelopathy. Nerve damage affecting the limbs, causing pain, numbness, tingling, or weakness is quite common, especially in advanced HIV. Myelopathy affects the spinal cord. Ocular disease is another area. Eye problems can be significant. CMV retinitis is a major opportunistic infection that can cause blindness if not treated promptly. You can also get tumors like Kaposi sarcoma or lymphoma affecting the eye. And one more classic mentioned, esophageal candidiasis, that's thrush in the esophagus, usually caused by Candida albicans. The absolute classic symptom is pain, specifically on swallowing, felt behind the breastbone retrosternal pain, usually treated effectively with antifungal drugs like fluconazole.
Wow, okay. That list of specific complications the diarrhea causes, Kaposi's sarcoma, the various CNS issues, eye problems, and that painful swallowing with esophageal candidiasis definitely feels like high-yield information to nail down for revision. And that really brings us towards the end of our deep dive into HIV, pulled straight from your MSRA revision notes. We've journeyed all the way from understanding what the virus is and how it attacks the immune system, through its stages, how it spreads, how we diagnose and monitor it, the different treatment strategies, and finally, the prognosis and potential complications.
Yeah, we hope that breaking down the material from your notes in this way, making it a bit more conversational, maybe highlighting the key facts, those lists, the clinical links, we hope it makes this pretty complex topic feel a bit more manageable and, easier to recall for your exams.
Yeah. So what's the big picture takeaway? I mean, the notes clearly show us that while HIV remains a really serious global health challenge, millions affected, issues like late diagnosis still needing work, the advances in treatment, especially RT, offer a genuinely hopeful picture for individuals diagnosed today. It enables long, healthy lives for most.
It absolutely underscores the power of early diagnosis and consistent, effective treatment. It's made a world of difference.
It really has. It certainly makes you think about the ongoing importance of testing, raising awareness, and ensuring access to care, not just here, but worldwide. Well, a big thanks for joining us on this deep dive. And hey, if you're finding this approach helpful for getting to grips with complex topics for your revision, remember there are loads more resources available over at passthemsra.com and also at freemsra.com. Definitely worth checking them both out.
Yeah, they have a wealth of material, practice questions, all structured to help you prepare effectively.
That's it for this deep dive, then. We'll catch you on the next one.